It's my pleasure to introduce Dr. Jerry Feldman, who comes to us from Detroit. I had to actually print out a couple pages, and I won't go through things in great detail because Jerry's a pretty modest, humble guy, and I don't want to embarrass him too much. But Jerry serves as the medical director for the Division of Laboratory Genetics and Molecular Pathology at Detroit Medical Center, and he's also the professor of pathology, pediatrics, and molecular medicine and genetics at Wayne State University. And just like we all have stories to tell, I'll tell one quick one, and this will put things in perspective. The very first year I was here as a fellow, I attended the ACMG conference, and it happened to be in Miami. So a few of us found our way to South Beach, because there's a little bit more going on at South Beach. One of the people that I found myself sitting next to was Jerry. And so having a Corona or two or more with Jerry was sort of a prelude to what was to come. He's obviously advanced significantly and done a lot of great things in his career. I'm pretty much the same. That hopefully will lend a little perspective. Jerry's an extremely knowledgeable clinician, and he has expertise on all fronts of laboratory medicine. And I thought I would just add one thing. Jerry just completed in March his 2-year term as the president of the American College of Medical Genetics and Genomics. And so one of the quotes about Jerry that I came across comes from Mike Watson, who was the executive director of ACMG. And this was around the time Jerry was nominated and voted to be, I think, the incoming president. But it reads, Dr. Feldman has a long history with ACMG, and through his extensive committee work, he's taken an active role in steering us to where we are today. His institutional knowledge and expert experience working across the full spectrum of clinical genetic services, promises in education will help our organization going forward in an era where genomic information promises to play a bigger role in medicine than it ever has before. And so Jerry is intimately familiar with a lot of the successes we've achieved as a collective field, but he's very aware of the problems and challenges as well. And so how did we get where we are today? I ask myself that on a daily basis. And so we look forward to hearing what you can tell us, and hopefully there will be plenty of questions at the end.
Thanks, Mike. I guess we got here from Miami. I didn't remember that story. So thank you guys very much for inviting me. This is my first time to Greenwood, and I must tell you I'm simply amazed at everything that's happening here. I was just telling Helen, I'm not making this up, but it's amazing campus. It's an amazing opportunity here for all of you guys, and what you guys have done is just very impressive. So what I wanted to do in this talk is really, first let me just give you a little bit of background about myself, and how I'm going to try and come full circle and talk about where I think we need to go. Not that we're going to go there, but I think it's where we need to go. So I do direct our molecular genetics laboratory, so that's a disclaimer, and I have oversight as medical director for the other genetics labs, but I don't sign out those reports. And then as Mike said, I'm past president of ACMG, but I want to emphasize that I'm not speaking on behalf of ACMG. I still represent ACMG as past president on the board, but these are really my opinions and don't reflect anything that is happening per se at the ACMG level. So I want to historically talk about how some of the current models for genetic services developed, both on the clinical and laboratory side, but how I think that they're not really sustainable as we move forward in the current healthcare system. I'll describe some issues that impact especially medical genetics and genomics, and I mean that to refer to both the clinical and laboratory folks. And then I'll talk about a couple of things that I think are opportunities for our geneticists to move forward on. So a little bit of background just about myself so you can see how my training brought me to where I'm at today. Wayne State University School of Medicine is the largest single medical school campus in the United States. We have about close to 300 students per year. It's a huge medical school in the sense of there may be other medical schools that have more total students, but they're divided up among various campuses around the state. We have all of our students on one campus, so it presents a challenge both from an educational level as well as from a training level. I co-direct the Year 1 Medical Genetics course, so I teach 300 medical students per year and try to emphasize to them the future of genetics also. At the medical school, our major unit is called the Center for Molecular Medicine and Genetics. It's really a basic science department. It doesn't have departmental status because it's considered an independent center and is supposed to be collaborative with all of the other departments. And our residency program is housed there, and our genetic counseling training program is housed there. But primarily, I'm one of the few clinicians that have appointments in the center. So that our major clinical unit is the Department of Pediatrics and our division of genetic and metabolic disorders within that division. And I'll tell you that our major challenge, which is a little bit different than you guys, is that Wayne State University is a state medical school, so it's a nonprofit academic institution primarily devoted to quote-unquote research. But the medical center, which I'll talk about next, is a for-profit. And so it's a challenge to work within the mission of a nonprofit institution with a for-profit hospital system. And so the for-profit hospital system is called the Detroit Medical Center. It's the largest healthcare provider in southeastern Michigan, and just some facts about how many employees and beds and physicians, etc. There are 8 total hospitals that comprise the Detroit Medical Center. Most of them are located on the central campus. Located here, so a number of hospitals and a medical school. That's the medical school building there. Hospitals here, those are schematics of the various hospitals. So there's 8 hospitals, most located on the main campus, with a couple located in the suburbs. But the most challenging part of that is what I mentioned here, and that is that we are the medical center, so not we, I'm employed by the university. We were bought first by Vanguard Health Systems and then sold from Vanguard to Tenet Health Care. You guys, anybody familiar with Tenet? I don't think they have any hospitals in South Carolina. They're the second largest for-profit hospital healthcare system in the United States. They own about 90 hospitals across the country. They're primarily based in Florida, Texas, Arizona, California, East Coast, Connecticut, Boston areas. So for-profit mentality and mindset changed dramatically when the medical center was sold. The medical center was previously a non-profit. And so that's a challenge to interact with the medical school faculty who are all faculty at the university. The medical center is also partners with the Carmanos Cancer Institute and VA Medical Center, and I say that because our molecular laboratory serves these hospitals as well, and that impacts a lot about our test development, a little bit different than you guys at least now. And so the lab system that covers the medical center provides services for the entire lab system, and also affiliated with providing cancer genetic testing for the cancer hospital as well. So our laboratory is made up of four main laboratories: our division, Molecular Genetics Laboratory, the Biochemical Genetics Laboratory, HLA Laboratory, which I have sort of oversight of, but completely as independent, and then our Cytogenetics Laboratory. This is just a picture of our laboratory. We have an integrated laboratory where there's 3 labs housed in this facility here that was built about 4 or 5 years ago for us. So our molecular, biochemical, and HLA laboratories all share space in that big lab picture on top of them showing you. Then we have separate rooms where DNA extraction and equipment is housed, but it's a shared resource, so we have some overlap with HLA. We share some resources. We share some technologists in the biochem laboratory. A couple of my molecular techs are cross-trained to run amino acids and organic acids. So it's more of an integrated approach. Our molecular genetics lab does inherited disorders, testing that you guys are all familiar with. I won't go through those. But we also do a fair amount of non-inherited testing. As I said, we're affiliated with the cancer hospital. So we do a lot of somatic cancer testing, including some next-gen sequencing, looking at some panels for leukemias, lymphomas. And we do a lot of single gene testing for solid organs. And that's probably about, right now, 60% or so of our volume in our molecular lab is related to acquired tumor changes. And the lab's made up of the usual people. I have 2 PhD technical directors, along with the other usual people. Our clinical genetic services are divided up among the various departments within the medical school and the medical center. So our PEDS genetics division has 5 clinical geneticists, 1 who's boarded in internal medicine, genetic counselors. We were talking a little bit about nurse practitioners. We have 1 nurse practitioner who's involved in taking care of the enzyme replacement therapy patients, and newborn screening for LSD is starting in Michigan in the fall of this year. And then on the biochemical side, we've separated out our newborn screening group because we have the state contract for providing newborn screening follow-up for the entire state of Michigan. So Michigan centralizes their resources into 1 particular site, so we cover the entire state of Michigan, including the Upper Peninsula, which could be as far as 10 hours away from us. And so we have a large group that's supported by the state for providing those services. So all patients with a positive newborn screen are referred to our site, to our medical center for confirmatory biochemical testing and then long-term follow-up. Cancer genetics, because Carmanos is a separate hospital, so they have their own cancer genetic counseling service, and prenatal genetics is done through the Department of OB. Okay, so that's just a little background that tells you my perspective on where I've come from, and I've been in Detroit for almost 30 years. I think we know the rapid change that's taking place in our clinical practice. Just listening to the conference that was just held today on whole exome sequencing just is a good example of the changes that have taken place, and it's really changed our practice approach, but I'm not sure that it's changed our practice. So I think it's changed our approach to patients, but not necessarily our practice. And I just listed a couple of things that I think the new technologies have really changed where we're heading, driven by new technologies. So this is me. Yeah, that's how old I am. But when we look at complex interpretation, secondary findings, and variants of uncertain significance, it's a whole new world, right? And I think it requires a transformative approach to our clinical genetics practice that I don't really think has been incorporated into everyday practice. And so I want to give a little bit of history about where we've got to where we are today, and then how this is going to impact both our clinical and laboratory models. So here's my perspective of medical genetics, and I wasn't there at the beginning, but you might think so. So historically, I think you could say that medical genetics began somewhere around 50 years ago in terms of clinical genetics or medical genetics, and it really operated out of departments of medicine. Do I need to put on this? I just realized I was supposed to put this on. Do I need to? Okay. Operated out of departments of medicine, primarily departments of medicine, Victor McCusick and all of his people that he trained. And they operated out of academic medical centers. Most of them were internists, and they dealt with monogenic or single gene disorders. And then there was really a switch in terms of looking at dysmorphology and prenatal diagnosis, and so that led to many more individuals trained in pediatrics and OB-GYN, and those departments then became the home for many geneticists, and in fact, many more than in internal medicine. These individuals were all really self-trained or trained because of a mentor who they were working with. And there was no certification in genetics, so they were all board certified in either pediatrics or OB or internal medicine or another specialty. And so it wasn't really until the 80s that the American Board of Medical Genetics was formed. Training programs were accredited and became certified, but that was still a self-designated board. In other words, it wasn't really considered a medical specialty compared to other specialties. And so it wasn't really until 1990s that medical genetics, and they recently added genomics, so the specialty is now called medical genetics and genomics, was recognized as a specialty on the same level as every other primary specialty. So OB or pediatrics, internal medicine, genetics became accredited as a specialty, and it's the 24th specialty of the American Board of Medical Specialties, and in fact it's the last one that's been accredited by ABMS. Okay. So genetics grew from that process into a clinical approach of seeing patients, and I want to go over with you some studies that may be old but haven't changed over time. And so if we look at the average number of patients that a clinical geneticist was seeing, this was a study done in 1999, they saw about 13 patients per week, 7 new genetics patients, 6 follow-up, and only a little over half of them thought they could see more patients. So if we think about other specialties and how many patients are seen per week, we know that that's not sustainable. Yet, in a study that was done 7 years later, a typical academic clinical geneticist spent half of his time in patient care, providing this number of patients, and if you divide that out, it's still roughly the same. They spent a fair amount of time in clinical activities. Face-to-face time, though, was less, and so they were doing other things that related to patient-related activities. And then a more recent study said that the average professional time spent per patient was about 7 hours per new patient and 3.5 hours per follow-up patient. Again, I think if you look at those numbers, you can see that in today's healthcare environment, that's just not sustainable, that a clinician can spend that much time per patient. There's still a single billing fee for that clinic visit. The time being spent with that patient may have changed in the sense that the genetic counselor's time may be counted now as part of that total time, or perhaps a nurse practitioner or someone else. And again, only a third of that time was spent in patient care, direct patient care, while there were other indirect kinds of patient-related activities that we would consider non-billable activities that were taking place. And so my point in showing these studies is that in every study that you've looked at, it's about the same time being devoted per patient as previous studies. And as genetic testing becomes more complex and more time-consuming, you might think that that's going to increase the amount of time you have to spend with the patient. But that's, again, in my mind, not a sustainable model for the future in terms of how do we balance our number of patients we see with the workload. And we were talking that there's an average wait time now up to 6 months here. That's our average wait time as well for new patients that aren't emergency patients. So just to summarize what I see is what happens at a typical genetics clinic. There's a fair amount of time spent, often by genetic counselors, on review of past medical records. They spend a lot of time trying to gather those records up and spend time seeing those patients for a patient who may not even show up to clinic. So review of past records, and then at the clinic appointment, typical kind of appointment, you assess the history, physical examination, look for a differential, think about what tests you might recommend, get prior authorization, of course, these days, and then genetic counseling, often provided by a genetic counselor. And then you may have a follow-up clinic visit to discuss the test results, or it may be done by phone. By phone is non-billable. And in this process, we've become very accustomed and dependent upon genetic counselors. There are genetic counselors here, yeah, who provide an invaluable service, and most of us feel like we can't run a clinic without having genetic counselors involved. But in many states and in many situations, that's not a reimbursable effort by them unless it gets counted in a physician visit. And the other thing I think that's happened over time is that genetic counselors are spending a lot more time on non-genetic counseling activities. So pre-authorizations and et cetera. So again, I would say that that's not sustainable as efforts move forward. And the question is, how did we get to where we're at today, and then where do we need to go in the future? And I think about this comic that some of you might remember that says, I won't read the whole thing, but basically the point is, we have met the enemy and he is us. So I feel like that we're responsible for our own situation of how we developed our genetics programs, and how we trained our residents, and how we train our genetic counselors. I'm medical director for our genetic counseling training program too, and we talk a lot with the directors of our genetic counseling program about what the genetic counselors need to do in the future, and it has to be different than what they've done in the past. And the same thing I talk a lot with our residents about. So let's look a little bit at how we got into our training programs and where we got to where we are today. When we developed these residency programs, I think we did a disservice to ourselves back then, in the sense that we required our residents to have at least 2 years of prior training in another ACGME residency. So basically we were saying we can't train our own, they need to do prior training first. And so essentially what happened was a lot of residents did an entire residency in another specialty first. And so while we were called a residency, we were really recruiting people who would think that they were fellows because they'd already completed one residency, but in fact, this was a second residency. And we didn't have the opportunity to involve medical students straight out of medical school. So all of them were going to do something first. Even if they were interested in genetics, many of them never came back to do genetics. They did internal medicine, they did pediatrics, they might have done a neonatology fellowship instead because they got interested in something during pediatrics instead. So recruiting medical students to me is the key to gaining our interest in genetics and keeping that interest. And I really don't understand the reason historically why that happened, but basically as others relate to me, it's they didn't think that they could teach residents medicine. The geneticists didn't think that they could. That they needed to learn medicine in their pediatrics or internal medicine training and then come to genetics. I would disagree with that. There have been some improvements in that process. It's been changed so that now that there aren't at least 2 years required, there's only 1 year required. But still, that applicant who wants to do just categorical genetics and become board certified in genetics can't match directly for medical school. So I don't think we fixed that problem completely. One of the solutions that I've thought of is a 3-year medical genetics residency straight out of medical school and just require a transitional year of 1 year. So you do 1 year of transitional year, which a lot of surgeons and other specialties do in terms of learning some medicine in the first year. But you could match directly out of that, straight out of medical school. How about the combined residency programs? And I'm just going to use a pediatric medical genetics combined residency program. Do you have a combined program here? The categorical combined. So initially, so again, I think we don't think highly enough of ourselves to do this, but the training took 5 years. So if somebody wanted to do a combined training program in peds and genetics, it was a 5-year training program, meaning that it was no different in terms of total time allotted than if you did pediatrics first and then genetics. It was still 5 years either way. And most of the students that I talked to were not interested in a combined program for that reason. They said, I can do pediatrics and then come back and do genetics. Many of them never came back. I think we fixed that program, and I'll show you some data that suggests that we did, in that we eliminated 1 year of total training, so now the combined PEDS residency program is 4 years instead of 5. Individual can be board eligible in both PEDS and medical genetics after 4 years. And so I'll show you some data that we think that has been quite successful, and I think that that's really one of the futures of increasing our number of trainees. So if we look at the total number of genetics residency programs right now, there are 46, with combined training programs in other areas besides PEDS. And the parentheses list the number of training programs in these combined specialties. And then there are 16 medical biochemical genetics fellowship programs around the country as well. And so if we look at the data, what do we see? We still see that there are 46 accredited programs, 184 approved slots. So that's how many residents across the country we could train, but there are only 146 total individuals in filling those slots, so there's still a lot of empty slots not being filled, so we still have some work to do. But if we look at the various combined residency programs, I'm encouraged by the fact that if you look, this is 2014, 15, 16, this is the most recent year that we have data available. You can see here that the number of individuals in the combined training programs has gone up each year. That's encouraging. And why has it gone up? Because this is around the time that the combined training program dropped from 5 years to 4 years. So I think that there's a lot to be said about the future of training in combined programs. The other thing that I will point out disappointingly is that internal medicine and genetics has really a small number of individuals going into that program and a small number of trainees. They still remain as a 5-year program, but hopefully that's, as I understand it, may be changed to a 4-year program as well, starting either this year or next year. So when you say, why is there a shortage of medical geneticists? We know here, you guys are recruiting for geneticists, we're recruiting. I have a trainee former trainee who just finished, 3 years ago and is out looking for another job. And she has interviewed at a number of places and has job offers from every place that she's interviewed at. And she's a fabulous resident, so that's, but the fact is, everybody's looking and nobody's hiring because these individuals are in high demand. And so why is that? Well, there aren't enough individuals choosing genetics. As I just showed you the data, I think part of it is the way that we set up our training programs. It's confusing for medical students. The reasons that the residents tell us or students tell me is, one, it's not a high pay specialty. That's something that I think we could fix. And a lack of visibility, as I said, because we're not there in medical school to get those individuals in their 4th year of medical school to think about genetics. So for us, for example, we teach our medical genetics course in the 1st year. We don't see the students again until they rotate, unless they rotate either in pediatrics and spend time in genetics or do an elective with us. So I think we've lost that opportunity. They might be very interested in their 1st year, but by the time they're 4th year, they're long gone. And as I said, there are funded slots that go unfilled, and so we need to do a better job of that. So I think the numbers are stable, and I think they will increase in some of the combined specialties, but other than that, we're pretty stable. And as I said, I think that we created this problem, and I think the history I showed you sort of makes you think that. And so we need to look at how we can fix it. So ACMG is obviously very interested in supporting training. We're not the ABMDG, which accredits and board certifies individuals, but certainly interested in increasing the number of trainees. There have been a number of pharmaceutical companies interested in supporting the training activities, and so there are now a number of training slots funded through the American College of Medical Genetics, including some slots for laboratory geneticists over the next few years. Shire is one company that's done that. And the idea that's discussed at the board level is not to fund the programs that already have funding, because there you're not increasing the number, but fund programs that otherwise couldn't take a trainee because they don't have funding. And so the idea is to try to support additional programs with additional trainees and not just feed the wealthiest. As you know, there's a new laboratory specialty in laboratory genetics and genomics. I think that was the movement that had to happen, and that was supported by ACMG. And summer scholars, you guys have had summer scholars. We've had one each year. I've had 2 that have gone into genetics after their summer scholars. There's somewhere around 20 to 30 second-year medical students each year. We're trying to look at the data very carefully to know whether this is a helpful program for increasing interest in genetics. And the data so far that we would say is that about between 5 and 10% of students who have graduated have entered into combined residency programs. So again, combined residency programs that can enter straight out of medical school. We don't have long-term data yet because some are doing residencies in other specialties, so it takes a long time if they come back to do genetics to know whether this is going to be successful, but it's well supported by industry. They think this is one of the better programs that they like to support. So there are opportunities there, both on the laboratory as well as the clinical side, and we need to take advantage of them. But I will say that there always aren't a lot of applications for these fellowship slots, which again surprises me both on the laboratory and the clinical side. So if you are interested, you should definitely apply. So my perspective on laboratories, I think similarly the genetic laboratories that started providing testing primarily developed from research-based labs, performing initially research-based testing because there was a particular geneticist who was interested in that particular disease, and so he developed testing, he or she developed testing for that particular disease. And so there were a lot of niche labs around the country that were testing this disorder or that disorder, and really not a concerted effort. I'll talk a little bit about ABMGG training programs that have been in place since the 80s, and then talk a little bit about molecular genetic pathology, which has not been around that long, but certainly trains a lot of individuals. Also keep in mind that there are a lot of laboratories that offer molecular testing that don't have ABMGG certified individuals signing out those reports. And while you might think that those are primarily offering cancer or somatic testing, there are a lot of laboratories that are a lot of tests being signed out by other individuals who are not certified by ABMGG. So if you look at the number of training programs, these are the numbers. Cytomolecular have about the same number of programs, but the number of trainees is certainly different, and this is again historical because it's going to change with the new laboratory genetics and genomics combined program. The reason why the number of cyto people is low is because most everyone who recently has trained in cytogenetics is also trained in molecular. So that's another reason why there's more molecular trainees. The new laboratory fellowship, LGG, begins this year, and there are 23 programs that are already approved, and they expect there to be a similar total number of programs as there are, so they don't think they're going to lose any programs, but time will tell about that. And then for clinical biochemical genetics, there are 24 accredited programs, but only about 15 trainees. So again, you can see that there's a shortage of individuals. Many of the classical biochemical geneticists have reached the age where retirement is a great option. And so I don't know that we're replacing as many as we're losing. So what about MGP, laboratory, as it relates to laboratory genomics training? The MGP Molecular Genetic Fellowship is a fellowship that was initially set up to for either genetics resident or pathology resident to enter. It's a one-year training program. There hasn't been someone from genetics going through that training track for 10 years, I think. So they're all pathology trained individuals for the last 10 years. They have, this year they have 54 current trainees and they have 66 slots, so not all filled as well, but certainly a higher percent than what we're doing. And if you look at the total number of boarded MGP fellows since 2007, it's 329 compared to 297 clinical molecular geneticists during that same 10-year time frame. So I think you can see that there's a trend for more and more molecular genetic pathologists to be trained in molecular diagnostics. And I was thinking about what are the types of academic, or what are the types of genetics labs that we have, and I divided them up this way, and you may not think that's good or not, but I was thinking about academic labs, commercial labs, and then combination labs, which really are academic labs historically, like the Baylors or Emorys of the world or Greenwood here. Some of those have been sold to commercial companies, so clearly don't fall into that category anymore. And I think that there's different strategies and different challenges for the laboratory based upon where you're located. The commercial laboratories certainly have the advantage of having deeper pockets. They often place a cap on patient expenses that I know we're not allowed to do in our lab. And I think the biggest thing that they offer in this day and age is administrative services for things like pre-authorization. So we're losing a significant amount of volume because the clinicians want to send samples directly to those laboratories so they don't have to deal with pre-authorization. And then I was just reading about these contracts that many of these commercial companies are signing with insurance companies that require the patient samples to be sent to that particular lab. So Cigna or Aetna have signed contracts with various commercial companies. So we're losing volume to that because the patient will come to clinic and the only place that they can be sent to is whatever lab they've contracted with. And then there are other accrediting agencies besides ABMGG and American Board of Pathology for training individuals that one has to consider in regards to the bigger picture, and I just listed a couple of other ones who have some type of certificate or training in molecular diagnostics. So what are the challenges that I see for our laboratory systems? One is there's so much more being asked for from the clinical laboratories to provide information on the value of their tests from the insurance companies. So providing clinical utility and economic value is a major question that's being asked all the time from insurance companies. Show me that that test is worthwhile and will change your medical management. And the payers expect improvement in the clinical outcome, so that's really what they're looking for, is changing clinical outcome. And you can define clinical outcome differently based on benefits to the patient or to the family or lots of other ways, but particularly they're not interested in some of those reasons that we think are very important. I think reimbursement for PhD medical geneticists or laboratory geneticists is a huge issue. That's not a state-to-state issue. That requires federal legislation to become recognized as a Medicare provider. So I would say that ACMG is looking at that as well. The difficulty becomes, if you go back to my last slide, that there are lots of other individuals who are quote-unquote boarded, who have PhDs, who are doing molecular diagnostics and also would want to be included in this process of becoming able to bill. So that's a challenge that ACMG has looked at. And then, as we've talked about, there are many different other areas that we're all concerned about in regards to the FDA or CMS And so many organizations are involved in that. And there are new challenges that obviously result from the current administration at the federal level. So I see lots of challenges to the future of academic laboratories because I think it's going to be difficult for smaller size laboratories to compete with the larger laboratories, especially those that are providing all of these kinds of additional services. And I have a meeting when I get back with our Vice President of Administration and others to talk about what kinds of things can we offer in our own medical system that will be competitive. Because if we're not going to be competitive, I'm not sure what the future of a lab such as ours, even though we have a pretty good volume, will be. I talked about the insurance companies that are partnering with commercial laboratories for this in-network coverage. And then the other challenge that's interesting is the direct-to-consumer testing companies who are marketing directly to patients and certainly could theoretically impact laboratories down the road. Reevaluating genomic test results, you guys were talking about that today, and I think there are reasons why that's important, but again, is it something that can be done in a way that doesn't disrupt the laboratory process and sustainable for a lab to do. I want to talk just a little bit about genetic counselors too, because I think as we change our healthcare model, we need to think about this as well. There are 37 current genetic counseling training programs in the country, and there's 7 new ones that have just started up, so clearly the effort is being made to increase the number of genetic counselors by increasing the number of training programs, and many training programs have also increased the number of counselors or students that they take. There is still a significant shortage of genetic counselors. Primarily, I think that's on the clinical side. And I don't think anybody could have anticipated this kind of shift to not only other medical specialties such as cardiology or neurology and who have hired genetic counselors, but the laboratory counselors, and especially on the industry side. So I think it's safe to assume that many clinics will not have the luxury of having a full genetic counseling staff for a number of years. So we need to think about how can we exist in a way where that's going to be a likelihood. So first, I think we need to act like the medical specialists we are, medical genetic specialists we are. I hear stories all the time of individuals having difficulty, for example, getting privileges to see patients in their hospital because they're not boarded in internal medicine or pediatrics. And so the hospitals aren't equipped to credential somebody in genetics, even though we're a primary specialty. That makes no sense to me. I think, again, it's historical because so many people were boarded in another specialty that we never really thought about it. So we need to think about the fact that we are a primary specialty and need to act like that. We need to think about why current trainees choose medical genetics. And in the study that I did with one of the genetic counselors at our institution, we did a survey of medical genetics residents and asked them why they chose genetics. These were the 3 top answers: previous mentoring by a geneticist, research in genetics, and their medical school genetics course. So are we all doing a good job of mentoring the students that we see? That's critical to not only get their interest, but keep their interest. There are some medical schools that have developed integrated programs through all 4 years of medical school in genetics, and I think that's something that more schools need to do. But in general, I think we need to be positive mentors, be proactive. I've had students tell me that they had a horrible experience on their genetics rotation because the clinicians were just always talking about how busy they were and how unhappy they were. And so, do we really think about what we're saying in front of other students? I think we have to put on a positive approach. And we know we're busy. I think they'll see that. And then the salary thing is interesting to me in terms of how this is happening and why it's happening. So we know that there are lots of unfilled positions, and institutions are willing to pay higher salaries because the clinic model doesn't cover or provide enough reimbursement for their time. So residents hear about this, or students hear about this, so residency positions go unfilled, and so there aren't enough geneticists to fill the open positions. So to me, it's a catch-22, it's a circular argument that I think we could fix. So here goes my Johnson, and don't throw stones at me. So I've thought a lot about this and thought about a new model for our medical geneticists to be really primarily a consultant as opposed to being that initial person to see that patient. And so let's assume that the genetic testing is the first step in the path to diagnosis. And let's assume that that testing could be ordered by a primary care physician with advice from a geneticist on which tests to order, and then referrals for the more complex cases. So instead of our current model, we have a pre-test assessment that's replaced by a post-test assessment. So in other words, we don't see the patient first, but we see them after the fact. And this is called reverse phenotyping. So let's take an example. Patient with intellectual disability has intellectual panel testing ordered by the primary care physician and then referred to the geneticist for discussion and interpretation of the results. If they're positive, that interpretation takes place by the geneticist. Primary care doctor is not going to want to be the person doing the interpretation. And that's when secondary findings could be discussed as well. If it's a whole genome that was done instead of a panel, the specific treatments would be managed by a geneticist. If that initial test was negative, depending upon what was ordered, the patient could then be referred to genetics for additional genetic evaluation and a more thorough physical exam. And that the clinic visit in that case would be limited to about 30 to 40 minutes. I know that's not anything that we currently do. I don't think. I know we don't. And so what this process could involve would be more telemedicine, more e-consults, less face-to-face time. Of course, we have to assume that these telemedicine or e-consults are reimbursable for this to be successful, for the geneticist to spend time pre-visit to discuss the case with the primary care doctor. So what kind of skills would be needed in this new model? Well, the clinical geneticist has to become better trained in things like bioinformatics and IT skills, e-consulting, be able to interpret the genomic variants, be able to participate or refer patients for clinical trials, and interface with other physicians in the care of those patients so that the patients are not coming back to the geneticist and taking up valuable clinic time if a diagnosis has already been made, unless they're being treated or being managed. And the primary care physician has to assume the ability to identify patients at risk for genetic disorder. So there's going to be additional training necessary for many primary care physicians, and willingness to provide this pre-assessment and refer the patient. And so we know that can also be a challenge. And what kind of current roles might be less important? Well, I see that the geneticist acting as a gatekeeper for genetic testing may be reduced because the genomic testing is going to be ordered by other physicians. Fewer patients will be seen face-to-face. The role in prenatal diagnosis is either way is going to be reduced as non-invasive prenatal screening becomes more mainstream. And it still will require the expertise for dealing with identified abnormalities. It will still require just morphology evaluations if a diagnosis isn't made and a particular syndrome might be apparent. So I think that there will still be roles that just might become less and less important as you move to a possible different model. And for genetic counselors, we know how important that licensure and reimbursement is, but that's really just one piece of this overall strategy to increase the number of genetic counselors. I don't think it's going to solve the current staff shortage in many clinics for a number of years. And so I think that's going to take a whole other effort in terms of how do we best utilize genetic counselors. I think they should be part of the process that's looking at discussing this complex information as more and more genomic testing is done. But do that as a post-assessment instead of the pre-assessment. So spending less time on the pre-assessment and more time after a diagnosis is made. And then obviously things like genetic counselor only appointments with MD supervision are important for counselors as well, and that obviously depends upon licensure and reimbursement for them as well. And then we need to figure out different ways of reducing the burden of administrative roles that they're currently filling. And one of the things that we've done in our clinic is to hire what are called genetic assistants. And I'll go over that in a little bit. There are many opportunities for institutions and organizations working with payers to substantiate and validate clinical validity, utility, developing practice-based guidelines. That's what the payers are looking for. But remember, an evidence-based medicine review is very expensive. It takes a lot of time, and so there need to be concerted efforts of organizations to collaborate together. I thought about offering a certificate called a precision medicine certificate, so clinicians would take a course, a short course, or some type of online training and get a separate certificate in precision medicine, which would allow them to have that extra expertise to be able to fulfill the role that I was just talking about. And there's been some question about whether non-geneticists should also be offered some type of certificate, but not board certification. I'll just throw that out there. So I did a study last summer with a summer scholar student, and what we wanted to look at was what things have clinics done around the country to decrease their wait time and increase their efficiency, and just send me everything that you've done that you feel has been helpful. And Teresa Kaminsky was her name, and we're hoping to publish this after she takes her USMLE Step 1s this summer. So here are some of the ideas that people responded to the survey. One is hiring non-MD and non-genetic counseling staff, and so more in the way of nurses, genetic assistants. We have 3 in our clinic right now. They're individuals who are aspiring most likely to be a genetic counselor, so they're not quite there yet. And so they're college graduates, may need to wait a year or 2 before they get admitted into a genetic counseling program, and so they're motivated to do well. They have a good background and interest in genetics, and so they function in doing things like obtaining medical history information, records, doing the pre-authorizations, those kinds of things. We need to perhaps do a better job of triaging patients for booking. That's what some of the respondents said. This is what we talked about just now: order routine genetic tests prior to genetics appointments so that those test results are available at the first clinic appointment. Normal reports reported by phone or EMR message with a mailed copy. Decrease the number of no-shows, and I think all of us have thought of many of these things, appointment reminders, etc. No-shows are a huge issue in our center. And one of the other things that I thought was interesting is no annual evaluations for patients so that they don't take up a clinic slot. So do we really need an annual visit for a patient with Marfan syndrome? And we're still collecting data on this, and so we're hoping to be able to put it all together. And so in summary, I think geneticists will continue to play a key role in diagnosis and management. I think management is going to be a huge opportunity for geneticists. I think there'll be emphasis placed on these new technologies to make the diagnosis as opposed to perhaps the way that historically it's been done. Sequencing is going to move forward in terms of even additional new technologies. We will still continue to provide core genetic services to patients, but they're going to be done a little bit differently, I think, using telegenetics or online consultations. We may become part of more multidisciplinary teams and developing lots of web-based interfaces that could decrease the amount of time spent in clinic. So this might seem kind of pessimistic, but I don't think it does. I don't want it to be that. Does our small workforce size mean there is no future? I don't think so. I think that it will be patient volume that sustains us, along with the value we provide. There's no shortage of patients that are being referred to genetics. So obviously there are lots of people who think our specialty is important. We just need to be able to accept the fact that we're never going to be a large number of individuals doing genetics. So we have to utilize our resources better and develop new practice models for patient care and training of geneticists. And we have to continue to demonstrate value that we provide. And with the whole onset of personalized medicine, I think that this is really where we need to think about as we move forward for both the laboratory side as well as the clinical side. And if you think about things like secondary findings, we won't be calling them secondary findings for long, I think. Those will soon become the primary finding as we're identifying preventable types of health problems. And that's going to form the foundation for the practice of genomic precision medicine. So I think our future is bright and sustainable. No other specialties on the cutting edge of medicine like we are, but we have to do more within to make it happen. And I think that the key is it's going to be related to genetic testing and medical information that's being generated from these tests. So I'll stop here and get to answer any questions.